Hi, good afternoon or still morning, everybody. Welcome to the Care Continuum session. It gives me great pleasure to introduce Meredith Clement, who's going to be your moderator for the next hour. Our apologies for being a little bit late. We've had some technical issues. Just to say, Meredith Clement is Assistant Professor of Clinical Medicine at Louisiana State University Health Sciences Center. She's an infectious disease physician scientist, and her academic interest lies in the prevention of HIV and STIs in vulnerable populations, which makes her an excellent person to be moderating our session, and we look forward to it. Thank you very much.
All right. Hi, everyone, and thanks so much for joining us today for the HIV Care Continuum session. I just want to get started by introducing our first speaker, who we're very pleased to have present today, Dr. Aadia Rana. Dr. Rana is an associate professor of medicine at the University of Alabama at Birmingham and an associate scientist with the UAB Center for AIDS Research, where she co-directs the Ending HIV in Alabama Scientific Working Group. Dr. Rana received her medical degree from UAB, completed a residency at Case Western Reserve in Cleveland, Ohio, and her fellowship in infectious diseases and HIV health services research from Brown University in Rhode Island. Dr. Rana's research focuses primarily on disparities in access and adherence to medical treatment among people living with HIV and implementation of evidence-based interventions to improve engagement with HIV care. Her NIH-funded work incorporates biomedical and behavioral collaborations to evaluate and implement adherence interventions using mobile health strategies, big data science, and novel therapeutics. The title of Dr. Rana's talk is Making HIV Universal Test and Treat a Reality to Achieve SDG 3.3. Dr. Rana, I'm going to turn it over to you.
Great. Thank you, Meredith. And thank you to IAPAC and the HIV Treatment and Prevention Adherence Conference co-chairs and session organizers for inviting me to be part of this important session. And really thank you for your commitment to holding this meeting and making it accessible to all of us. It's definitely the meeting that I look most forward to attending every year, and particularly to talk about a topic like the HIV Care Continuum. So I was asked to speak on making HIV universal test and treat a reality as part of the United Nations Sustainable Development Goal 3.3. And I'm going to be focusing my talk on the role that rapid start of antiretroviral therapy can play in helping us achieve this goal. So just to orient us, the United Nations Sustainable Development Goals, the UN SDGs, also known as the global goals, they're actually 17 goals with 169 targets that all UN member states adopted in 2015. And they agreed to work towards these goals by the year 2030. Health has a central place in the third one, which is to ensure healthy lives and promote well-being for all at all ages. And this particular goal is underpinned by 13 targets, and it covers a wide spectrum of World Health Organization's work. And the third target under SDG is that by 2030, to end the epidemics of AIDS, tuberculosis, malaria, and neglected tropical diseases, and combat hepatitis, waterborne diseases, and other communicable diseases. So fairly broad, certainly ambitious, and very relevant and timely, especially with regards to those other communicable diseases these days. But what we're going to focus on is the indicator 3.3.1 within this target, which is to track the number of new HIV infections per 1,000 uninfected population by sex, age, and key populations. So why is test and treat even possible? And so first, we have a variety of well-tolerated once daily options, often as a fixed dose combination that allows for the majority of people with HIV to have their treatment as simple as one pill once a day. And then in 2011, we have our first results from HPTN 052, which really shows the success of early ART initiation versus delayed in mixed HIV status couples. And this was a study that was almost exclusively among heterosexual couples in Africa and Asia, but really was acknowledged as a breakthrough of the year in that it showed that prevention of HIV-1 infection. And the final results published in 2016 reported no phylogenetically linked sexual transmissions among over 1,700 couples who were followed for a median of 5.5 years, while the person with HIV was on antiretroviral therapy and had a viral load of less than 400 copies for at least 6 months. We subsequently have the Partner study and then the Partner 2 study, which provides even more data from a diverse population of mixed HIV status couples, in which where condomless sex was common, over 100,000 episodes of condomless vaginal or anal sex, while the Partner has an HIV viral load less than 200 copies. Again, no phylogenetically linked transmissions occur. And then we have the START study, which shows early start of ART versus deferred, where they waited until the CD4 count dropped below 350. That early initiation not only saw reduction in the number of AIDS-related events, particularly in lower CD4 counts, but also significantly reduced the rate of serious non-AIDS events. And of course, if we consider all aspects of test and treat, so if you test somebody and they test negative, they could also be considered for eligibility for pre-exposure prophylaxis, which has been shown to be effective in preventing transmission of HIV as well. And so with this data, we have in 2017, HIV-MA endorses the U=U consensus statement that people with HIV on ART with an undetectable viral load have negligible risk of sexual transmission of HIV, supported by all of the studies, as I mentioned before. And we also have this statement in the United States from the National Institutes of Health that endorses that message. Undetectable equals untransmittable. So if we have safe and effective, well-tolerated therapy, we know it's better not to wait and to go ahead and start, both for individual benefit, but also public health benefit. Why don't we start as soon as possible? And so we have several studies that try to answer this question. Why can we start, and what is the impact of us starting as soon as possible? So we have these 4 large studies in low and middle income countries where rapid start is more evidence-based, really driven by high rates of late stage HIV presentation and loss to follow-up, which obviously negatively affect morbidity and mortality. So we have these 4 high-quality randomized control trials: RAPID, which defined rapid initiation is within 90 days of HIV diagnosis; START-ART, which took place in Uganda, defined it as less than 14 days of an ART initiation after diagnosis; and same-day ART in both Haiti and Lesotho. And in this summary of these trials, what we find that when we look at the outcome of virologic suppression at 12 months, that we do see a benefit favoring rapid ART in this Cochrane database systemic review. That in this particular outcome of virologic suppression, we certainly see an outcome that favors rapid start. This is both seen in those who are on same-day ART, as well as those with additional definition of within 14 days. And when we look at the outcome of mortality, we also see at least a trend in that direction, although the confidence interval does cross 1 here. In terms of safety from that outcome, we still see a trend from these studies favoring rapid ART. In the United States, we don't have large randomized control trials in this same format, more single site experiences, but we are also seeing these similar trends. So the first sort of gold standard site to initiate same-day ART was in San Francisco, the RAPID program. And what you can see in this chart on the left is that the proportion with viral suppression starting in 2013 to 2014, the time to suppression decreased to less than 2 months compared to CD4 guided ART earlier, which was greater than 6 months, and even within universal ART. Our experience in Birmingham, a state in the Deep South impacted by many disparities in access to care, found the same thing. Our program considers rapid initiation as starting ART within 5 days of referral. And we see a significant difference in time to viral suppression in the fast track group compared to the standard of care. Most of these differences are certainly driven by the time to getting the first prescription of ART. And then I just want to bring up in New Orleans at Crescent Care, this data was presented at CROI earlier this year. When we look at a particular population that has challenges in achieving the benchmarks of the HIV care continuum in adolescents, you see the similar outcomes in those under 24 years of age or equal to 24 years of age and greater. Very high rates in both achieving viral suppression, sustained viral suppression after 12 months, and those who are engaged in care. So what we are seeing is changing of the guidelines starting to reflect these findings and these experiences. So both the Department of Health and Human Services and IAS USA encourage rapid initiation of antiretroviral therapy and include language to say same-day start if feasible. They have recommended regimens which do take into consideration the fact that transmitted non-nucleoside reverse transcriptase inhibitor or NRTI resistance is more likely than protease or integrase resistance, to consider coverage for empiric hepatitis B coverage, and to think about treatment suitable for patients with a creatinine clearance of greater than 30 mLs per minute. The World Health Organization also recommends immediate ART for all persons with HIV, and that initiation should be considered within 7 days of diagnosis, ideally on the same day. There are caveats, of course, as it relates to presentation, particularly with opportunistic infections such as cryptococcal meningitis or concern for tuberculous meningitis. Immediate ART initiation in these groups may increase the risk of serious inflammatory response syndrome, and so a short delay before initiating ART may be warranted if the clinical syndrome is consistent in that presentation. Certainly after ART initiation, the patient should be closely monitored for signs and symptoms associated with iris. There has been some concern with regards to retention with rapid ART. 2 studies in sub-Saharan Africa indicated that women who were started on ART the same day they were diagnosed with HIV and their pregnancy had slightly higher rates of loss to follow-up. And a study in France also indicated that there may be some low trends to lower rates of retention in same-day ART initiation. And I think what that's reflective of is that we need to understand what rapid start is in practice. So in the top area, we see all of the different steps that were often part of what we would now consider prior standard of care, in that after diagnosis, there was a first clinic visit where insurance, housing status, education, counseling, labs were drawn, followed by a primary care visit to assess preparedness, and then potentially either that day or on a subsequent visit, ART start, and then ART management. With a rapid visit, a lot of these elements are often consolidated into one visit, or perhaps spread out only in 2 visits. So that includes understanding whether the infrastructure at your site is able to incorporate some of these elements that are key to successful linkage and retention in HIV care. So modifying the model to reflect that all of those components from your initial standard of care certainly will require planning on the part of the clinic. And I think the other thing to emphasize is that Rapid Start is not simply the prescription of a pill, that there needs to be a focus on all of the other items or all of the other factors that play a role in assessing barriers to care and treatment if we truly want this model to be a success. So understanding the demographics that can inform challenges to accessing care and treatment, whether it's issues with discrimination, or we talked about adolescence briefly, substance use, mental health, poverty and how it relates to the competing responsibilities of trying to engage in care, stigma, and not just HIV-related stigma, but all of the intersectional stigmas that occur, whether it's race, gender, poverty, simply forgetting to take your medications, and adverse events to medications. And I think that the one thing to emphasize that we've seen is that Rapid Start can promote equity. We've seen in the US that Black men are more likely to experience delays in ART initiation even after seeing a prescribing provider, and that Hispanic persons are significantly less likely to receive ART after meeting clinical indications for treatment. So same-day immediate access to a provider can demonstrate commitment to a community. And Dazon Dixon Diallo, she's the founder and president of Sister Love, which is the first women's HIV sexual and reproductive justice organization in the southeastern United States, speaking at the Fast Track Cities meeting in London last year, said, "See my brothers and sisters as your own. If you do, then of course you will see patients same day, start same day, and love same day." And Dr. Jason Halpern at Crescent Care in New Orleans shared some of these quotes, talking both about U equals U, but also how it relates to the importance of the offering of Rapid Start. So I'll just read one of these. When I was first diagnosed, my first thought was not, am I going to die? Because you know everyone is going to die. It was, can I give this to my boyfriend? That terrified me. I started medication on the day I was diagnosed, and I am now undetectable. So the answer is no, I cannot. So empowering our patients as soon as they receive their diagnosis can play a critical role in helping them, of course, manage their diagnosis and perhaps help to build that key patient-provider relationship that is essential in ensuring continuous engagement in care. So as we all know, worldwide HIV services have been severely impacted with decreased rates of HIV and STI testing during the COVID pandemic, and it has been reported at other conferences. Refill lapses in PrEP and antiretroviral therapy have been reported despite rapid implementation of telehealth visits. And so at ID Week, just a little less than 10 days ago, we had a presentation from Chicago describing some increased diagnoses of acute HIV through ED screening and rapid linkage to care and initiation of ART during this pandemic. So the University of Chicago reviewed HIV screening data from their expanded HIV testing and linkage to care program, which is a consortium of about 15 affiliated healthcare sites on the south and west side of Chicago, which have already implemented for a while now routine HIV screening. And the first thing they noted that there was marked reduction in testing in the ED by approximately 50% through May, which was still down by about a third at the end of June. They found increased rates of acute HIV that were diagnosed in the emergency room. And the rate of acute HIV was significantly higher in 2020 compared to the prior 4 years, with acute HIV infections making up 25% of all new diagnoses, which is the highest proportion ever observed. From when they presented this to an updated, they've gone from 9 to 12 acute HIV infections through October 16th. And of the 9 patients for which they had detailed data on, the median viral load was 6 million copies. One patient did have a COVID co-infection, although all with similar symptoms to COVID-19. I think the one thing I want to point out is that all patients were notified, linked to care, and initiated on ART. So within 1 day of result from confirmatory PCR and a median of 3 days from presentation as a result of delayed reflex testing due to the high demands on lab personnel and scarcity of reagents. And so just to close this editorial that was published earlier this year, looking at critical components to rapid ART, that it will take planning, coordination, teamwork, and funding, which is going to be critical to any rapid start program design. So having cooperation rapport between both testing and rapid ART sites, which are firmly ensconced within them warm handoffs and accessible linkage coordinators, making sure that access to ART is not a one-off, it's both early and sustained, working through the clinic format to ensure that payer source and insurance and same-day clinician visits are possible, but making sure that we don't have any drop-off in education, and certainly implement follow-up with continued education, patient navigation efforts, and contact with retention teams. And so we know that this is going to take quite an effort, and making sure that we have the policies and procedures in place at every level, both at the sort of motivational level of the providers and the clinics, but also at policy levels will be key. And so just as a reminder, all policy is health policy ultimately. So today, don't forget, if you haven't already, to vote because your voice matters. Thank you.
All right, thank you. Yes, everyone, please do vote. Your voice matters. And Dr. Rana, thank you for that excellent talk. I did love what I'm going to call your rainbow slide, which was showing kind of that paradigm shift, because it really has been a true paradigm shift, based on some of the Crescent Care experience that you highlighted. All our Ryan White clinics in New Orleans now have rapid start programs. So it is so important, and thank you for that fantastic overview. All right, and so now we're going to jump into our next presentation. I'm going to introduce Dr. Altice here. Dr. Rick Altice is a professor of medicine, epidemiology, and public health at Yale University, where he serves as the director of clinical and community research and community healthcare VAN and HIV in prisons program. As a clinician, he is board certified in both infectious diseases and addiction medicine. As a researcher, his interests are focused on the interface between infectious diseases, including HIV, tuberculosis, and viral hepatitis, and substance use disorders. Specifically, he is interested in both prevention and treatment issues and has been at the forefront of both behavioral and biomedical intervention research activities. He is also interested in creation of novel prevention and treatment programs for the treatment of HIV, viral hepatitis, tuberculosis, and substance use disorders in vulnerable populations, including people who inject drugs, criminal justice populations, men who have sex with men, and both cisgender and transgender sex workers. Dr. Altice has spent considerable time devoted to developing and studying integrated systems of care, including integrating medication-assisted therapies into managing comorbid conditions, including in people living with and at risk for HIV, hepatitis C, tuberculosis, and mental illness. In more recent years, given the many successful prevention treatment interventions available, Dr. Altice has increasingly become involved in implementation science to find improved ways to disseminate research and evidence-based practices and ensure that they are implemented using best practices. Dr. Altice is currently leading studies in Ukraine, Eastern Europe, Central Asia, Malaysia, Indonesia, Peru, and the United States. And the title of his talk is Optimizing the Care Continuum for People Living with HIV with Opioid Use Disorders. Dr. Altice, I'll turn it over to you now. Thanks so much.
Meredith, thank you so much for that kind introduction. And had I known that you were going to get that one, I wouldn't have even given my talk. There was so much to be said. But thank you so much. And Dr. Rana, thank you so much for that talk. That was actually really helpful. And one of the things that you sort of pointed out was that these rapid start programs are really an issue around health equity. And this is going to be the one place where I think that health equity has not been achieved. And so I'm going to try to walk through some of those issues around optimizing the care continuum for patients with HIV and opioid use disorder. I don't have control of my slides, but if you could advance to the next one, these are my disclosures and funding. And if you could go to the next slide, please. I just want to point out that we are still making progress, but with the HIV Care Continuum and our goal to get or to meet our 90-90 targets, we are still behind. This is as of 2019. And had we moved forward with the fast track sort of solution, we would have prevented 3.5 million infections between 2015 and 2020. And part of that has been that we have sort of not achieved our sort of goals along the HIV care continuum. And if you advance that slide one step further, you'll see that this care continuum, despite the fact that we have made major progress, is markedly diminished among people who inject drugs, of which globally, about 82% of them have an opioid use disorder. So this interface between opioid use disorder and HIV is really quite profound. Next slide. One of the things that's really also important with the HIV care continuum is that it's not equal around the world. And if you advance one more, you will see that there are at least 2 regions where HIV incidence and mortality are increasing, and they are doing so in places where there is suboptimal access to treatment and prevention. And so the 2 regions where HIV is continuing to increase and mortality is increasing is in the Eastern European and Central Asian region, where 50% or so are of people living with HIV are people who inject drugs, primarily of opioids. In Ukraine, where I spend a lot of my time working, that number is about 82%. But in other regions, because of the sort of the opioid distribution routes from Afghanistan, it's really approaching 100%, although there is some increase in stimulants in the region. And also in the MENA region, about 43% of patients who are inject drugs have HIV. If you'll advance one step further, you'll see that if you go to the Asia Pacific region, mortality and incidence have not increased overall, but there is inequity even within the region, with countries such as Pakistan, Malaysia, Indonesia, etc., having sort of a high proportion of people inject drugs that are driving their epidemic, but they are also having increased incidence and mortality. And then if you advance one step further, you'll see that as we move towards some of the more high income areas, such as Western and Central Europe and North America, where people who inject drugs account for about 15% of the population, we are seeing some decreases, but we're seeing inequality even within countries where for instance, in the US, where our evidence-based strategies such as medications for opioid use disorder and syringe exchange programs are unequally distributed, and we are seeing a fair amount of outbreaks. Whereas if you go to Western Europe, coverage of these kinds of services really exceeds international targets set forth by WHO. Next slide, please. So one of the things that I want to point out is that we spend a lot of time, and I'm going to frequently go back and forth and use Ukraine as an example, but we've created our sort of HIV treatment cascade where we have to get patients diagnosed on antiretroviral therapy and achieve viral suppression. And in this region, we are certainly far lower than we see elsewhere throughout the world. But I want to state that in order to sort of manage both of these conditions, we have to have a care continuum also for our treatment of substance use disorders. If you'll advance to the next piece, this is the care continuum for the 336,000 or so people who inject drugs. And among those, ideally, you need to get 40% of those patients on medications for opioid use disorder to sort of stop the epidemic from advancing, and at least 20% to start to reduce the prevalence and incidence of HIV. But in a place like Ukraine, you've only got 17% or so who are sort of diagnosed, that is, they're eligible to get treatment. And of those, there's only 4.3% who are on some kind of opioid agonist therapy. And so if you'll just advance one further, you'll see that the coverage rate, even among those that is at 7 of the ones that are diagnosed, it looks like that the coverage rate is 25%, but your denominator is really the large number of people who have not entered into systems of care, because there are a number of structural issues which make it challenging for patients to get onto therapy. And in places like Ukraine, initially there were requirements that you get registered. The registration would require then that you might lose your driver's license, be unable to be employed in certain kinds of work, which is common for many people with HIV and who have opioid use disorder. So there were huge amounts of barrier just even in the first step, much of which was structural. And then, of course, there's a number of barriers, just like with HIV, in terms of the entire workup, which has sort of been diminished. And I will make an argument that we need to do the rapid start for for medications for opioid use disorder in the same way that we've created great opportunities for HIV, and to really bend the curve on the cascade. If you'll sort of advance to the next slide, we have a lot of data looking at the treatment cascade and what works for opioid use disorder. Clearly, the only evidence-based treatment that we have is medications for opioid use disorder that include methadone or buprenorphine. Extended-release naltrexone has also evidence for treatment, but there are 22 randomized controlled trials and multiple systematic reviews and reviews of reviews that really show that it's not only efficacious for treating the underlying substance use disorder, it reduces opioid use and retention in care by 8 to 9-fold. It reduces injection risk by 9-fold. It reduces overdose, death, and criminal activity. It also increases engagement in care, including for HIV, increases the likelihood of employment, improves quality of life and social functioning, and is incredibly cost effective. So unlike antiretroviral therapy, methadone on average costs about 6 pennies per day. Its efficacy for HIV prevention is that for primary prevention, it reduces the risk in systematic reviews by about 54%, but it reduces it more when patients are treated with an adequate dose. And for people with HIV, it improves care along the HIV continuum. Let's go to the next slide and talk about what some of the problems are, though, and as it might relate to treating HIV. And so one of the problems is that no matter where you go in the world, perhaps with the exception of Western and Central Europe, the ways that we think about treatment for opioid use disorder is incredibly diverse. And these are data from Sarah Wakeman, who's in Massachusetts. And she did a very elegant study looking at Medicaid data for over 41,000 patients who met criteria for having an opioid use disorder. And what she did was she looked at their trajectories for treatment, that is, what they actually got. And if you can see that most patients got non-intensive counseling, they might have gotten very intensive counseling, they might have even have gone to an inpatient program, detox, or residential services. 8% got absolutely nothing whatsoever, and only 12% got a medication for opioid use disorder. But what's really intriguing, if you just look at the outcome for overdose and serious hospitalizations, what you see is that for these 6 different strategies, these trajectories in health, that only opioid agonist therapies reduced overdose and reduced serious hospitalization. And all of these other things that account for 92% of the treatment really has no benefit whatsoever. And unfortunately, there's a great disconnect between the way that our dollars for addiction treatment are spent for sort of non-evidence-based treatments versus the 12% who actually do get into treatment. Next slide. So let me just talk a little bit about the issues around diagnosis, engagement in care, and viral suppression for patients with co-occurring HIV and opioid use disorder. Next slide. So one of the first things that we need to do is we need to think strategically about how do we get patients diagnosed. And if you sort of look along this care continuum, our outreach into the communities through our harm reduction programs, et cetera, would have the broadest band, but such programs do not exist universally where we may need them. In fact, there is a great disconnect with the current opioid epidemic in the US, which has moved to suburban and to rural settings. These kinds of programs are less likely to be available. We have approximately 55 to 75% of people who inject drugs and who have HIV who go through our criminal justice system, whether it's through arrests or our jails or our prisons. We have a much smaller proportion who go into our drug treatment programs, primary care settings. A number of our patients go through this. Some of them may be sort of seen as an emergency response, a non-fatal overdose. They might make it to our emergency departments. They might come into our hospitals with other kinds of infections, maybe perhaps not related to HIV. And these are all potential settings where we should be thinking strongly about doing routine testing at that time. And I'll make the point later that it should be routine testing, and then we should move it towards rapid start ART, which has not been done in any systematic sort of way, and rapid start medications for opioid use disorder. Next slide. So the other sorts of opportunities that we have for these patients is to reduce their risk of death from sort of by providing naloxone distribution and overdose education, and advance it one step further by having a rapid start for ART, next for medications for opioid use disorder. Next slide. So what do we have with regard to linkage to and retention in care? We have a number of broad-based interventions that have been used in a number of different settings, including RTAS, which is a strengths-based case management. And this is a really wonderful case management intervention. It's been, there's both been two randomized trials, and it's been primarily beneficial in newly diagnosed patients with HIV. But one of the key things that's, I think, a lesson for patients with opioid use disorder it was less effective for certain key constituencies, including those with substance use disorders, mental illness, and for those who are out of care. So moving to the next step, really looking at those individuals who might be perceived to be at increased risk for being out of care. Patient navigation, whether with peers or with professionals, a systematic review looking at 20 studies showed that it was mostly beneficial, 17 out of the 20 studies. The quality of the data were somewhat weak. None of these interventions focused on people with opioid use disorder, so the extent to which this works in that setting is unknown. And then I will say that of all the studies that Dr. Rana presented, none of those included people with OUD. And in fact, the one study that's got a wide country scale up in Thailand is not including patients with opioid use disorder. And while there is interest in doing that sort of work, there's only pilot studies that are underway, one of which is ours with 35 patients, where we have pretty good data in a very, very small amount of patients. But for all the reasons that Dr. Rana suggested, there are a number of other extenuating circumstances that can occur. Next slide. So one of the things that we've been sort of thinking about is for patients with substance use disorders, and including opioid use disorder, does patient navigation work? And probably, and this is among the 20 that were in the systematic review, this is probably the one that was done incredibly well, which is a randomized controlled trial looking at treatment as usual on the far right in the baby blue, and looking at patient navigation where they could get up to 11 sessions over 6 months, and they looked at outcomes at 1 year. And there was also a pay for performance incentive as well, where patients could earn up to $1,120 over a 6-month period if they were able to achieve a number of things like get to the doctor, see the doctor again, to get into drug treatment, to get into mental health services, all of those other sorts of things. And what you can see is that overall, irrespective of the allocation, and the patients were matched pretty equally, and they all had to have a substance use disorder in order to get into the study, of which about 40 or 50% was an opioid use disorder. You see that your treatment success, that is, that it would include viral suppression and death, was really overall about just under 40%. If you look at viral suppression still, the numbers are really quite far from our targets, our 90-90-90 targets. And then the mortality in this group, these were patients that were mostly recruited from hospitals in this multi-site trial. Mortality was high, between 10 and 12%. Now, there was also no differences in terms of whether they saw an HIV specialist, whether they received antiretroviral therapy. Once they got the antiretroviral therapy, interestingly enough, there was really quite extraordinary adherence. But if you take a look at what happened with regard to them getting into drug treatment, only about 7 to 10% got a medication for opioid use disorder. That is the only evidence-based treatment. And if you sort of advance this slide, you can see that what they ended up getting in terms of their treatment, in which they got paid for, is they got paid for a number of non-evidence-based treatments, such as seeing a professional, going into residential treatment, outpatient treatments, NA and AA, all of which have not really demonstrated a major benefit with regard to outcome, unless a person stops using drugs completely. And that occurs for about 10% of patients who get those treatments. Next slide. So what do we know about putting patients on medications for opioid use disorder in the HIV treatment cascade? Aadia Rana and colleagues really conducted a really elegant systematic review, looking at, on average, about 8 to 10 studies, looking at least 3 elements of the cascade, that is getting on antiretroviral therapy, once on it, adhering, and achieving viral suppression. And as you can see, that there was a 54% increased likelihood of getting on antiretroviral therapy if patients were on medication for opioid use disorder, and that likelihood increased the longer they were on medications. Adherence was increased twofold, and viral suppression was increased by 45%. It also had the added benefit of looking at dropout from treatment, and that was reduced by 33%. So at least for many of the stages on the HIV treatment cascade, there seems to be a clear benefit from really thinking about sort of co-administration of ART or HIV care and medications for opioid use disorder. Next slide. These are data from Ukraine, looking at the cascade here. And as you can see, that at every single step along the cascade, there were about 520 patients with HIV in this particular study. Most of them were not on opioid agonist therapies. About 40% were. And as you can see, that at every single step of the cascade, you have an added benefit for patients who got opioid agonist therapies. And for the first time in any country that has an epidemic that's driven by people who inject drugs, you see the first step of the cascade achieving a number at greater than 90% in patients who are on opioid use therapy. So suggesting that perhaps this is going to be one of the linchpins in order to sort of achieve your 90-90 targets. Next slide. And as you can see, that as you go down the cascade, that the number on antiretroviral therapy is increased by about 25%. Next slide. So these are one of the reasons why in a place like Ukraine, this is a study that is under review right now, but it really looks at some of the structural factors like within clinical settings. And we use feeling thermometers to sort of try to identify how HIV treating clinicians sort of view their patients overall. And patients with HIV, interestingly enough, there was not really the level of discrimination because these were HIV treatment providers. But when you started to look at some of the key populations who were at risk for HIV, there was a decreased positive attitude towards MSM. And then, of course, lowest among the group were people who inject drugs. So this begins to get at one piece of the puzzle. And on the next slide, these physicians were sort of tasked with an experiment to sort of look at various different patient profiles at various different T cells in the absence of an opportunistic infection. And one of the things that you can see here is that in general, they would withhold antiretroviral therapy for patients with more advanced disease relative to those with less advanced disease. And that may be in part related to their concerns around iris and the risk in patients with more advanced disease. But if you take a look across the board here, what you see is that patients with ongoing substance use disorders are significantly more likely to have their antiretroviral therapy withheld that you see on the far right. And if you advance the slide, you can see that likelihood of prescribing antiretroviral therapy goes down markedly if a patient is placed on medications for opioid use disorder, once again suggesting that the treatment of the co-occurring substance use disorder is really quite essential for the clinicians to make the decision. Now, I will say from a health equity perspective, it should be a test and treat, and ideally with both. Next slide. So when you looked at these same clinicians and sort of looked at what I call the demand characteristics of who would initiate therapy, only 8% of them were willing to sort of see the patient on that day and treat them. And this is in a place where there's supposed to be universal treatment, and the idea of getting patients onto treatment within 7 days, but only 8% would do so. And that was even lower than for patients who inject drugs. And overall, on average, there was about 2 additional visits beyond the first visit that they would require before they would actually think about initiating antiretroviral therapy, which draws from some of the same issues that emerged in Africa, where patients would sort of need to have multiple counseling sessions. They might need to practice with jelly beans or something like that to see if they could take their medications. Next slide. And then here are some data looking at quality health indicators. One of the things that we hope in patients with multiple co-occurring diseases, and in a place like Ukraine, the most common, the most prevalent opportunistic infection is TB. And we looked at HIV quality health indicators, addiction treatment indicators, and TB, HIV, and addiction treatment indicators. And we found that these quality health indicators were significantly higher in patients who got integrated, or in this case, co-located services, relative to those who just went to an addiction treatment setting versus those who were HIV positive, who injected drugs, but were only going to an AIDS center. Next slide. This is borne out further in a more recent study. These are data from 2013. Can you advance the slide for me, please? And this is really looking at several thousand patients who were on opioid agonist therapy. So we're sort of adding that piece, keeping that piece constant throughout. And as you can see that the ones who got their care in integrated care, rather than getting their care separated, were significantly more likely to get antiretroviral therapy and achieve viral suppression. And moving to the next slide. This is in an ongoing study that we are doing. It's a 36-site cluster randomized trial looking at treating addiction in specialty care settings versus primary care settings, where there's integrated services, and then adding on a pay-for-performance for physicians, not for patients. And as we can see, that looking at composite quality health indicators that included addiction, HIV, TB, and primary care, that the sites that were integrated had consistent higher quality health indicators across all of these conditions independently and collectively, suggesting that when you integrate these services, you can take care of their HIV, you can take care of their addiction, but you can also make sure that they're screened for mammograms, their blood pressure is monitored, their lipids are monitored, et cetera. So this is a more comprehensive way of looking at how integrated care improves treatment outcomes. And I will say that because these primary care physicians were not experienced with addiction treatment, HIV or TB, they got their sort of education through collaborative learning using Project ECHO. Next slide. So I will just say briefly that release from prison is really a dangerous notion. Patients with HIV who are released have poor linkage to care afterwards. They have much lower retention in care, and their mortality relative to patients with HIV who are not incarcerated is 8-fold higher, and it's most commonly from their untreated HIV because they are not linked and adequately retained in treatment. Next slide. And this is a modeling study that we did where we looked at 3 different settings, really sort of pointing to the notion that context matters. We looked at rural Kentucky, Kyiv, which has got the highest prevalence of HIV, and in Tehran, where they have the largest proportion of patients who are on opioid agonist therapies within the prison. And we looked at the modeling at 4 different scenarios on the next slide. These 4 different scenarios looked at agonist therapy, 3 different scenarios, the status quo, and then just scaling up opioid agonist therapies in the community, getting to what is the international recommendation of 40%. And what we looked at with this is looking at what its effect would be on death, but also on HIV outcomes. We looked at if you actually retain patients on treatment for 2 years or more. And then we took the 3rd scenario and we then not only scaled it up in the community, but we scaled up opioid agonist therapies in the prison. And you can see that irrespective of the context, each added layer, including getting patients on treatment in the prison, resulted in the highest likelihood that patients would not die. But it also had the greatest benefit on HIV and transmission, primarily in the Kyiv setting. Next slide. So what are the strategies moving into the future? I think that we've got some really compelling data, and we should be thinking about this release from prison, but maybe also for patients with problematic or challenging adherence, and that is long-acting medications, and we can potentially combine them with some of the data from the rilpivirine and cabotegravir trials. But we've got long-acting buprenorphine, which lasts for a month, or implantable buprenorphine, which lasts for 6 months, and other sort of injectables. But I think that we're going to, on the next slide, need to think about what some of the patient preferences are and what will be the retention strategies to keep patients on these injectable medications, especially when the timing may be different for them, 1 month, 2 months, 6 months, etc. Next slide. And then I want to just say that we should really think about COVID as turning a crisis into opportunity for patients with co-occurring HIV and opioid use disorder. This is a look at what happened in Ukraine with take-home medications. And on March 16th, the government said, please make it more convenient. Patients don't have to come in, but every 10 days to get their medications. If you are willing to sort of move them out, we had a differential response. But one of the things that you can see is that moving patients to 10 medications every 10 days instead of every day as daily observed, you can reduce the amount of patient contacts by 1.2 million contacts. That makes it the demands on the patient markedly less with that, and that would basically involve 84,000 fewer hours. What people are concerned about with addiction treatment is that patients are going to overdose. So we carefully looked at that in the mortality before COVID in 2019. It was 4.3%. In the immediate pre-COVID era in early 2020, the mortality was 5%. And the mortality among patients on opioid agonist therapies in the subsequent 6 months is only 4.2%. So we can safely transition patients, and we actually have higher retention, and we're able to do sort of this treatment with much fewer demands so that we can keep patients on treatment. So moving to the last slide. If I could just sort of give a summary for where I think we need to be, we should really link and routinely implement HIV testing and on rapid ART and OAT at a multiple different touch points, such as harm reduction, clinical care settings, and criminal justice settings. We really need to figure out how to adapt the rapid start to really create that sort of equity that Dr. Rana spoke about. And I think it probably could be done by co-linking it to medications for opioid use disorder. These are 2 different systems of care, and it can be integrated. And I think that we should begin to think about how to integrate services where possible. There's incredible resistance to doing that, but implementation science is making great strides in doing that in a number of different ways. And I think that we really also need for interventions that address multiple layers of stigma, as we saw from the physicians who would not prescribe, not only for what I call not just the single veil of stigma associated with HIV, But the stigma around opioid use disorder, the medications that patients don't get because people don't prefer to give it to them, and then the issues that result in enhanced or elevated mass incarceration. Thank you very much.
All right, Dr. Altice, thank you so much for that fantastic overview. And I just want to let everybody know that because we did get started a few minutes late, we will be running a little bit late with the end of this session. So I just appreciate everyone's patience and attention. And I'm going to move on to introducing our last speaker, who's Dr. Lee Fairlie. She's the Director of Maternal and Child Health at the WITS RHI and has significant clinical and research experience in pediatric, adolescent, and maternal populations, including HIV and comorbidities, TB, and vaccine-preventable diseases. She obtained her MB-CHB from the University of Cape Town in 1997 and her pediatric specialist qualification from the University of Witwatersrand in 2005. Dr. Fairlie has worked as a pediatrician in the HIV and infectious diseases field since 2006. She has led the maternal and child team at WITS RHI since 2011, initially as the technical head and then as the director from June 2014. She is the co-chair and principal investigator of a number of studies and leads a team conducting clinical trials, implementation science, research, and clinical work, providing technical assistance. The clinical and research work which she leads focuses on prevention and treatment optimization of HIV, TB, and vaccine-preventable diseases, particularly in women, children, and adolescents. And she serves on the National Department of Health and Southern African HIV Clinician Society HIV Guideline Committee for Children, Adolescents, and Prevention of Mother-to-Child Transmission. The title of her talk is Integrating Reproductive Health into HIV Care Continuum. Why is it important? And Dr. Fairlie, I'll let you go ahead and get started. Thanks so much.
Thanks very much. And thanks very much for the opportunity to present. So changing track, I'm going to be discussing integrating reproductive health into the HIV continuum. Why is it important? And we know that women living with HIV face many challenges. Generally, women bear the greatest burden of HIV disease. We know that adolescent girls and young women are particularly affected by HIV. Often, the social, sexual, and reproductive health needs of women living with HIV are not met, despite many improvements in HIV care over the past 2 decades. We know that challenges exist around equitable access to healthcare for women, and that they are disproportionately affected by gender-based violence, including sexual and reproductive rights violations. And we need to be applying a women-centered approach, which is really central to many local and international guidelines. And this excerpt from the Consolidated Guidelines on Sexual and Reproductive Health in Women with HIV really highlights this point. And I think as we've heard much about the HIV care continuum, but certainly at each step, there are opportunities to ensure integration of sexual and reproductive health services, and going to focus more on what the issues are that we really need to be thinking about in women. So I've divided this up into different stages in women's lives, and obviously many of these stages may sort of overlap, but I think it's potentially quite helpful to look at the different issues that women might be facing at different points. So really the key issues for adolescent girls and young women, so for those who've been vertically infected with HIV, it would be disclosure to adolescents, and we know that that still is difficult in many contexts and many parts of the world. Disclosure onward to sexual partners, family and friends. Ongoing stigma, which really is pervasive despite us being many decades into the HIV epidemic. Evolving puberty, sexuality and sexual debut in young people. Concepts around treatment as prevention in a population where actually adherence may be quite challenging. Access to PrEP and PEP, identification of and treatment of sexually transmitted infections, preventing unplanned pregnancies, And we know that there's data lacking in vulnerable groups such as transgender adolescents. We know that sexual maturity may be delayed in adolescents living with HIV, probably around 6 months, and this is mainly related to growth delays. We know that sexual debut may be delayed between adolescents with and without HIV infection. Young people with HIV may actually have particular challenges in accessing contraception and condoms compared to those not living in HIV. There are high proportions of condomless sex and transactional sex in studies from sub-Saharan Africa. Variable results, though. In the UK, higher condom use was actually reported in people living with HIV and young people living with HIV compared to those not. Poor knowledge generally of STIs amongst young people. And we know that high risk behaviors are often associated. So, alcohol and drug abuse, reduced levels of viral suppression, and risk taking behavior, sexual behavior may all occur together, and they tend to be quite interlinked. We've heard a bit about treatment as prevention, and certainly in adolescence, this is an extremely important message. But obviously, this only works if the person is virally suppressed and for a particular period of time. And as I mentioned, with adolescents, we often do find a number of challenges in maintaining optimal adherence for many reasons. There's also very little data which is actually aimed at adolescents, looking at the acceptability and impact of messaging around treatment as prevention. PrEP, obviously a very important vital intervention in young people, but access is generally still limited. And again, we may see some adherence challenges in adolescents. Currently, oral PrEP is quite widely available in countries, but rollout is probably not as optimal yet as I think we would like to see. Other options for PrEP are currently under study or registration, and this includes the injectables and the dapivirine vaginal ring. And then obviously PrEP and potentially treatment as prevention may require some element of disclosure, I guess, particularly if someone perceives themselves to be high risk and that their partner should be accessing oral PrEP. And this is obviously particularly when when a young person is not virally suppressed. There's obviously a clear unmet need for contraception. Um, we know that over 75% of pregnancies in young women are unintended. In a study from Spain, only 25% of adolescent girls who were sexually active, living with HIV, and did not want to conceive, only 25% were using contraception. Obviously, we need to be considering drug-to-drug interactions, especially, for example, efavirenz and the subdermal implants. Also, oral contraceptive the oral contraceptive pill may have reduced efficacy with some of the protease inhibitors and potentially efavirenz, and we may need to switch regimens. And also the need to consider offering emergency contraception in HIV clinics, for example, the copper IUD or double dose levonorgestrel, highly effective in preventing pregnancies in young women who have not been accessing contraception. When we look at HPV and cervical screening, in some work done in South Africa, almost a third of adolescent girls and young women who were living with HIV were positive for high-risk oncogenic HPV, which is 10% higher than in HIV uninfected young women. The vaccination is obviously highly recommended, and HIV clinic could be a really valuable platform to provide the vaccine if it's not available in a school platform, and for older girls. And then also men, especially men who have sex with men. But access still is limited in certain parts of the world to HPV vaccine. We may also not get optimal coverage amongst the four most important high-risk types, and many country guidelines actually delay cervical screening, but certainly this should be implemented as early as possible after sexual debut. When we look at older women, obviously with a treat-all approach, we expect close to full life expectancy and in women and men living with HIV. Fertility intent and rates similarly have actually narrowed between women living with HIV and those not. And obviously, this requires increased focus on integrating sexual and reproductive health and HIV care. This often the difficulties with this actually lie within operationalization of these integrated services. Some people postulate a one-stop shop model or referral model within the same facility on the same day. And I think it's important to note that implementation in a research setting is often more successful than in real life settings. So we really need to think about how we implement this in our daily clinical care. In terms of fertility, in older women as well, 14 to 62% of women living with HIV who become pregnant report that their pregnancy is unplanned. We know that the recent, I guess fairly recent now, TPAMO findings regarding dolutegravir and neural tube defects really created, I think, havoc in the HIV treatment world, particularly around optimal treatment for women and women who were planning to conceive, and has certainly introduced complexities. Although those the weight of those findings have now been diminished, and I think that the investigators are reporting a slightly increased risk of neural tube defects in women who conceive on dolutegravir. Some in-country guidelines, so for example, South African guidelines, are still cautious peri-conception and in the first 6 weeks of pregnancy, which obviously really makes the treatment exceptionally complicated because there are different regimens for women who are planning to conceive or in early pregnancy compared to women who do not have pregnancy intent. WHO has recommended dolutegravir for all women. Contraceptive access and uptake is variable, particularly in high-burden countries. We know that global shortages of various methods, for example, injectables, is highly problematic, and this is certainly a problem that we have seen recently with COVID. And we need to make sure that women have access to safe termination of pregnancy. When we're looking at safer conception practices, in this recent review, generally there is access to the basics of safer conception implementation, treatment as prevention specifically, and voluntary male medical circumcision. But the more expensive or advanced interventions are generally only available to the sort of general public through research studies, and these might include things like oral PrEP or sperm washing. Some of the barriers, so amongst couples, a lack of awareness, limited integration of these services into HIV care. Fertility discussions really mainly happen around PMTCT and not upstream in terms of actually planning for that first pregnancy and really exploring couples' pregnancy intent. Stigma, and then difficulties with disclosure within a discordant couple. In healthcare workers, lack of training on safer conception services, again, limited integration, health workforce capacity shortages, and then guidelines may not readily be available to all. When we look at STI screening and management, obviously this includes a number of different STIs and treatments. But we know that most STIs, ulcerating and non-ulcerating, increase the risk of onward vertical and horizontal transmission. So regular symptomatic screening is necessary. In high-risk populations, such as female sex workers, we really need to be considering periodic presumptive therapies. Cervical screening also needs to happen early after the initiation of sexual activity and should happen after 12 months if there were any precancerous findings, otherwise every 3 years. And we know that antiretrovirals does reduce the risk of high SIL and CIN incidence, SIL progression, and does increase SIL and CIN regression. And we also know that antiretrovirals reduce invasive cervical cancer incidence. And just really to highlight some of the issues that women still face, this particular study done in Rio de Janeiro looked at trends in sociodemographic, clinical, sexual and reproductive characteristics over a number of different years, so 1996 to 2017, and really did serial baseline, collected serial baseline information at various different time points in 1,300 odd women living with HIV with a median age of 36. And we can see here that really, 11% of women reporting prior syphilis, high rates of oncogenic HPV, relatively low rates of hormonal contraceptive use, many women really still using barrier methods, very few women actually using dual contraceptives. When we look at pregnancy and postpartum, and this is a very simple case that I'll just run through quickly, but I think really highlights the issues in this particular population. This 27-year-old woman was postpartum. She had delivered a healthy infant who remained HIV negative really throughout our period of follow-up. She had been virally suppressed at delivery, but then had a bump up in her viral load at 3 months to almost 40,000. She lost contact with her care system and then came back into care at about 18 months. She may have been accessing treatment at some point because her viral load is of a fairly low level, but still, obviously elevated. At 24 months, she disclosed that she was 6 months pregnant at this stage, still really with this ongoing viral load. And then based on her resistance tests, which I'll briefly show you, which as we can expect, she had high level NNRTI resistance and high level lamivudine resistance. She was switched to based regimen. But I think really just highlighting that we see postpartum women. We know also that pregnancy and postpartum themselves are high risk for HIV acquisition. With new HIV infection comes an increased viral load and risks of potential transmission to the infant. There are many issues in women postpartum, including difficulties with return to work, juggling multiple roles, and gender-based violence. We know that postpartum is a high-risk period for virologic failure, and in this study from Johannesburg showing that this is particularly true in women who conceive on ART rather than women who actually initiate antiretrovirals in pregnancy. The viral suppression rates, depending on on various different studies, can range between 30 and 98% peripartum, but overall, around about 50% of women in some of these studies maintaining suppression through 12 months postpartum. In a study from Nigeria, again, relatively low contraceptive use postpartum, mainly relying on barrier methods with women also accessing the combined oral contraceptive pill, and then much lower numbers, the intrauterine device. And obviously the major concern and what we saw with our patient is that women then enter their next unplanned pregnancy potentially with an elevated viral load and increased risk of transmission to the infant with a resistant virus. I don't think any talk at the moment is complete in 2020 without some word of COVID-19. And I think really just to show that all of these integration issues become even more important in our current COVID world. And we, I think, are all really aware of the fact that the current COVID-19 pandemic really threatens to derail many successes regarding HIV. There is evidence suggesting that COVID itself may result in worse outcomes in people living with HIV related to immune dysregulation and inflammation. But as important are the issues that we're actually seeing around access to antiretrovirals, PrEP, and supportive services, and these may be related to many factors, including low stock, healthcare worker fear of contracting COVID in a clinic, closure of facilities, in some cases, police responses to the state of emergencies during lockdown, not allowing people out to go and access treatment. COVID-19 has certainly increased the socioeconomic vulnerability in people living with HIV, and really calls for further enhanced efforts towards patient-centered community approaches. And I think just to highlight from this document from IAS that ensuring sexual and reproductive health and rights is really one of the key things that we need to be focusing on. So how do we move integrated services forward? Well, I think the need is really obvious, but the challenges are really around implementation and operationalization of these. Some of the enablers, stakeholder engagement, capacity building, an enthusiastic staff contingent, and certainly a champion within a clinic, non-stigmatizing services, and involvement of key populations in planning these services, inhibitors, lack of funding, stakeholders who are not involved, staff capacity, so both from a human resources and skills point of view, poor program management, and a lack of infrastructure. And from a client point of view, low literacy, lack of male partner involvement, stigma, and a lack of women's empowerment for sexual and reproductive health decision making. So the approaches are not likely to be a one-size-fits-all approach. Programs need to respond to local context, which may differ remarkably between geographical areas. Certainly from one clinic to another, we know that issues can be vastly different and in different populations. Pilot projects for new ideas are probably necessary with scale up, but also I think we just need to figure out how we're just going to do it. So in conclusion, integration of reproductive services into HIV care is essential. We need to focus changes and approaches for women at different stages of their lives. Throughout, we need a woman-centered approach. The challenges are often not new. In fact, many of them have been around for many, many years in the HIV epidemic, but new ways certainly are required to overcome them. COVID has heightened these challenges and really, I think, even further highlights the need for us to address them. Thank you.
All right, thank you so much. And I just want to thank all the speakers today, Dr. Rana, Dr. Altice, and Dr. Fairlie for their excellent talks and overviews. Unfortunately, we don't have time for questions. We need to move right into the next session. So I'm going to close this out, but just thank everyone for your attention. Thanks so much to the speakers. And I'll echo Dr. Rana's closing slide for all the US participants today to please vote. And thanks so much. We're going to close this one out, and then we'll be back in just a couple of minutes with the next session. So thanks, everyone.